Took DMT and developed a Jesus complex. DMT is the active ingredient of ayahuasca. It causes you to disassociate. You more or less, therapeutically, are supposed to see your problems as unimportant, or at very least as not part of your existential being. People use ayahuasca, DMT, and other hallucinogens to solve depression, addiction, get over forms of post traumatic stress. You can see it being better adapted now in the last decade in the United States, but it's principally been associated with traditional medicine. Ayahuasca or DMT has been used by indigenous Americans for the last 3,000 years. And so the fact that Aaron Rodgers, the celebrity, a white guy, middle class, upper class white guy from the United States, is now using this medicine, this traditional medicine, as a form of therapy. It might also be a form of recreation. I know a lot of people who do it recreationally and they claim that it's a therapeutic type process, but it can be used as a party drug as well. It can be used as a different type of recreational drug. You don't necessarily have to be jumping around at a party. You can have fun just sitting around taking the drug too. So anyways, there's this really big question about appropriation of traditional medicine, this traditional cultural knowledge being appropriated by white neo-colonial institutions and individuals. Our contemporary dominant form of medicine in this United States is biomedicine or Western medicine. This contrasts with ethnomedicine, which is traditional medicine. Anthropologists have looked at biomedicine and how it constructs our realities in many different ways. Emily Martin has written an excellent article, one of those classic anthropology articles, that analyzes all of the medical textbooks produced in the 1950s and asks how are they reproducing gender norms when they are talking about sexual reproduction. If you look at the process of sexual reproduction, I might sort of butcher this, I apologize, but it's two gametes that come together and make a zygote. It's something that is genderless. We have no gender norms or social roles assigned to those two cellular structures that then reproduce. Emily Martin, though, notes that these medical textbooks often assign masculine qualities to the sperm and feminine qualities to the egg. So, for example, the sperm is aggressive, independent, and ambitious, whereas the egg is domestic, docile, and passive, waiting for the sperm to come and do all of the business. And if you look, this is not necessarily what aligns with the actual medicine and the actual science behind it. The egg has a important role in not only summoning the sperm are also more or less blind. It's a crapshoot. There's millions of sperm released, and it's just sort of process of elimination until one gets to the egg. And then when the egg is fertilized, it sort of calcifies and doesn't allow any other sperm to come in. So really, instead of the sperm being the one that's ambitious and in control, the egg is the one that is doing all the work and creating the situation. So the question then is, how does biomedicine function like other aspects of our society in order to create specific types of representation that then reproduce social roles and social hierarchies? And in this case, we can see that the discussion of the hyperaggressive sperm and the passive egg is meant to reproduce the idea of a man being able to be aggressive and outgoing, and women encouraged to be more docile. What are some ways that we can observe everyday healing in biomedicine? You can go do participant observation or ethnography, go and sit and hang out and be someone who is participating in a medical environment. So, Paul Farmer, as a doctor, he is participating and he's also observing. So, he's being a doctor, a practitioner, and then he is also documenting his observations and sharing them in an ethnographic way. You can go and observe clinics, how doctors and patients interact, the social structure of a clinic. If you ever go to a clinic, right, you have doctors, you have nurses, you have administrators, you have janitors, you have health other people, you have patients. So there's all these different types of roles you can understand and analyze. You can look at illness narratives and interview people about their illness process. So I started getting sick at this time. It affected my life in this way. And then I got cured and it affected my life in this way. I'm just thinking of a big illness in my family in the last 10 years. My mom had breast cancer, and she was actually the most optimistic one. But you better believe I know exactly every single step of the way how her diagnosis went, as well as the treatment, and now she's been in remission for the last 4 years. She went through chemo and everything. So, thinking about that specific narrative, some people aren't as fortunate to be cured and get into remission, and sometimes there's bigger effects that people have other than the disease, and it's sort of a domino effect. And then we can look at health decision making analysis. Obviously, my family was very supportive of my mom going through chemo, but there's some people who decide I don't want to go through treatment. And you can ask yourself, what are the reasons why people don't want to do specific treatments or others? And it might have something to do with cultural knowledge or cultural beliefs. Biology has informed human development and evolution, including the adaptations that have made our culture, language, and social living possible. Culture, in turn, informs choices that can affect our biology. So, food, medical practices, healthcare practices, work, and how work can affect your physical and mental well being, exercise, other types of disease or sanitation factors that might exist in a specific cultural environment. We can see all of these things affect our body and how we view our bodies, and that is also something that we can document. Can look at medical ecology. If you're a geologist or, a geographer or an ecologist, this would also be a place where medical ecology can play a role. But we can see in terms of going back to that Franz Boas type analysis, where you are, your social, cultural, and geographic conditions influence the health outcomes that you have, and you can map these out. So you can study the effects of environment on health outcomes. Looking here, this is a map of Wisconsin, of Milwaukee. Once again, in the red, you can see the hospitals that were active in the early 90s and closed. After 2013, you can see the ones that were not present in the 1990s and then were active in 2013. And then you can see ones that were active both in 1990 and then continued to be active in 2013. And what you'll notice is on the north side of the town, you see 3 huge hospitals closed down. One on the very east side was a university hospital, and the other ones are in relatively impoverished neighborhoods. So the question then is, once again, just like the food deserts, just like other types of outcomes, how does proximity to a hospital affect long-term medical decision making and medical outcomes? We can talk about idioms of distress. Who are the healers? What are the symbols of health or disease? What does it mean when you're diseased? What are the intentions of curing and medical practices? And then what are the results of those practices? So just thinking of different linguistic categories that we can define distress and disease. And then getting back to Haiti, we can see Paul Farmer giving a really good example of this. So, Paul Farmer sees this thing called structural violence. This is a type of violence that is not necessarily immediate, but one that is embedded in social systems. And for Paul Farmer, he sees structural violence in Haiti stemming from three historic traditions or conditions. First is slavery. Once the Haitian state was formed in the 1890s, it instantly abolished slavery. Slavery was something like 99% of the population, and it instantly abolished slavery. The rest of the slave owning world, pretty much Europe and the United States, did not like that result, so they prohibited Haiti from participating in global trade. They put huge indemnities and debts on Haiti because French people were really upset they just lost all this wealth because they lost all their slaves, and so they charged Haiti for freeing themselves. And for 150 years after the Haitian Revolution, you really see this lack of democracy, this type of dictatorial regime that leads to corruption. So you have slavery, this 200 or 300 year history in Haiti about slavery. You have the post colonial process, which more or less reproduced some of the inequalities responsible for slavery. And then you see corruption stemming from that. You don't see a healthy political environment. And all of these things led to the AIDS pandemic, as well as the lack of preparation for the earthquake and tsunamis that hit Haiti over the last few decades, as well as a number of different types of political turmoils and things like that. If we want to talk about a healthy medical situation, it's not going to happen when you have slavery, post colonial conditions, and corruption still having a dramatic impact on the creation of hospitals and clinics. And so, corruption, the stealing of money, might not immediately cause violence, but if it takes food out of people's mouths or if it prevents people from getting vaccines, then it's going to cause a different type of violence, a type of violence that's associated with maltreatment or disease. Can talk about synthetics as well. You can think about the intersection of multiple comorbidities. If you remember from COVID, there were questions about whether someone died from COVID or whether they had a different disease and they just happened to have COVID at the same time. It was one of those, once again, things where it was like, we want to discredit COVID. I'm not necessarily sure what I think about it. People dying while they have COVID seems like COVID might have been a factor. Nonetheless, other debates to have. We can see in Hiroshima high rates of cancer. Can see that misinformation about whether cancer is caused by an atomic bomb blast that happened in the 1940s or whether it's caused by something else. And then you can also see the stigma that's associated with many diseases. Things like lung cancer in the 1970s and 80s, people would be smoking and dying from lung cancer, and that would be highly stigmatized. People would more or less be blamed for the disease that they got. Similarly, during the AIDS crisis in the 1980s, it principally affected young gay men, and it became a entry point. The AIDS epidemic became an entry point for people to practice prejudice. So we can think of all these different types of intersections, all these different types of social conditions that could possibly lead to harm, distress, or disease, and how they sort of build off one another. Can also look at evolutionary medicine and medical anthropology, so the intersection of evolutionary biology, human health, using the framework of evolution and evolutionary theory to understand human health. So, evolutionary medicine looks at adaptation. For example, when people migrate, they bring genes with them. If they have children, they pass those genes on in new combinations. However, in this new world where migration patterns and culturally defined rules intersect, we can see that migration has encouraged specific genes to be present in environments that they are not necessarily adapted for. One thing I always think about, a specific example of this, is the presence of a anti-malarial gene. So malaria principally affects these darker areas near the equator, can go up into the southern United States, southern Europe, and all the way down to the southern tip of Africa. You can see that there's green areas where malaria doesn't exist, and in those areas, people are far more susceptible. The genetic populations that have evolved over the last 10,000 years in those situations have very little resistance to malaria. Whereas if you go to the malarial zones that are near the equator, there are specific populations that have a higher resistance rate to malaria. Unfortunately, those same populations have developed something called sickle cell anemia. And in the United States, sickle cell anemia is frequently associated with African Americans because many of them descended from populations in these malarial zones. Coincidentally, though, you'll see in indigenous populations in South America as well as in India, you'll see similar types of anti-malarial genetic adaptations as well as that presence of sickle cell anemia becoming more prevalent. This we can see is a pattern of adaptation and then dislocation. So, what would it mean to track these genetic populations and cater a medical treatment plan based off of your genetic profile and the ways that your genetic existence and makeup is defined by a long-term process of evolutionary adaptation? Shifting a little bit, moving beyond medical anthropology, for the remainder of the course, I'm going to be talking a little bit more about museums and museum anthropology. This is also very applied, something that's continuing to be part of the conversation and evolving and very different than it was in the past. In possibly about the 1950s, we see a shift away from just having basic collections, collecting things, organizing them in a nice, orderly fashion, and then presenting to the public, and rather a process of trying to make meaning and experiences around those objects. Here on the screen, I have a really good example of that sort of transition. It was at the Milwaukee Public Museum. This is a bunch of wax figures that are modeled after real people who are dressed in all of their native garments that they practice with. It's a powwow, conglomeration or confederation of various different Native American groups that meet in a celebratory fashion. And modern day powwows could possibly include a prayer and a indigenous invocation of some form, but it could also include like a band playing or a comedian coming and visiting. It's more or less a meeting between different tribes. And so this is meant to emulate what the actual encounter looks like. If we would just have the collection, we wouldn't have this representation of these lifelike individuals. If you were there present, you would hear a recording recorded by the people who are being represented. And so you can see different layers of meaning getting created other than just this is the object, look at what it is. The history of anthropology museums really tracks this very similar pathway of just getting like taxidermied objects, presenting them in cases. Here's the Milwaukee Public Museum's MPM initial building. It's currently the library in Milwaukee, the main downtown library, but you can see here just sort of lines and lines of glass cases that exist. And you would just go and look and you'd be able to compare and see examples, and it was very useful. It was a very publicly useful setting, but it didn't necessarily represent anything as it would be in context. Whereas if you look in the 1950s, and this is the museum building built in the 1960s in Milwaukee, very much modeled after this idea of making meaning, trying to immerse people within these objects, trying to take people to a more realistic setting, And then also this idea of cultural relativism. So let's try to present these culturally specific artifacts in a way that reflect how the artifacts are implemented and seen in everyday life. And you can see also just like the difference in the architecture. It's still very much a warehouse, but what you see is a lot of very different unique settings and staging areas. And you can go and, for example, there's one of my favorite. You can go into an igloo and you walk into the igloo and there's sort of like a clear glass divider and you look into all these life-sized wax figures, a whole family living in the igloo, and there's like a kid who's like 5 years old. It's just incredibly surreal, and they just did such a great job. Here's a example of one of the objects in the Milwaukee Public Museum. It is a bunch of monkey heads that were decorated to look like shrunken heads from Papua New Guinea headhunters. And there are some human remains throughout the Milwaukee Public Museum. One of the significant transformations beyond trying to be culturally relativistic is to identify culturally sacred objects or human remains that were misappropriated from their source communities and return those objects. So if you have a mummy and you know what community it came from, reach out to the indigenous people of those communities, the leaders, and see if they have a process of receiving those objects. And there's a lot of money out there from the federal government in order to encourage these types of returns. And it can be somewhat expensive to do so because you have to involve a lot of important people and highly skilled people to do these type of transfers. The new museum in Milwaukee that is already broken ground, so this is a mock-up, is going to replace the 1960s museum, replace those dioramas, replace those real-life representations, and more so try to create experiences. So try to be interactive. Those dioramas were not interactive. They were somewhat immersive and culturally relativistic and realistic to some extent, but they did not have the patron interact with the exhibit necessarily. And so this is important for new types of museums. You might have gone to a museum where you could go and play with something, interact with it. Obviously, museums are mostly for children, especially the publicly visited ones. They're educational resources. So let's go and get some types of interaction. And so the new museum is going to be a little bit safer. It's going to be a little less focused on collections and presentation of thousand-year-old artifacts, and rather it's going to be more flexible and it's going to be meant to be more interactive. Very controversial. There's a lot of people who like the old museum and they don't want to see these new interactive ones, and they're going to spend $240 million to more or less build a amusement park, an educational amusement park. So interesting to think what the role of research is going to be, interesting to think about what museums are going to be in terms of education and the role in a broader society as we get towards this more experiential philosophy rather than the collections or the realist presentation of a set of artifacts. So in conclusion, we can ask, what stories do we tell about our everyday lives? What stories do we tell about our bodies? And what stories do we institutionalize? We're going to continue these discussions and these questions in every single week that comes. So think about these three key terms: everyday, bodies, and institutions.